Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Hey.
Welcome to the show. We're excited. Sorry, we're a minute late. Oh, no, we're like 4 minutes late. Oh, my goodness.
Way behind.
I'm so sorry. There was such a long line at Dutch.
But totally worth it.
Thank you, Lindsay and Twine. So we are going to speak today about the Dunning-Kruger Effect and about I Know My Body, which I know how it could come across, what we put in the description and in the title. We want to assure you patients having symptoms matters and is important, and doctors need to listen to them.
Yes.
So
start out with that. Absolutely. Yeah. Yes, and we are fans of shared decision making,
yes.
Which is where doctor and patient have a conversation about values and appropriate care, and both parties kind of bring in their perspectives and make a decision on that. With that said,
we have comments. So, getting to the comments, we have, of course, Lindsay Antwine with I Know My Body Needs Help.
I know my body needs
Lots of love.
Perfect.
Yes. And
okay.
And oftentimes that is what a patient presents with, is they know something's not right.
Something's not right, yeah.
And that's when it's time to investigate. And interestingly, I will say, the broader or the more general and less specific the complaint that the patient is presenting with, the more aggressive and broad our search has to be. Maybe I shouldn't use the word aggressive.
Yeah.
Sometimes a stepwise approach. That's one thing that I realize patients don't always see at first glance is medical conditions oftentimes are a collection of signs and symptoms and test results. But the other part of it is there's another dimension over time.
Right. Time can reveal something.
These things can change over time. And so it may not be a single moment of looking at the illness or the patient, patient-centered.
Mm-hmm.
Now we had...
and there can be, I was just going to say, and there can be a tremendous overlap of symptoms from different causes that can give you similar feelings. So it can be difficult to sometimes distinguish those. Even as trained physicians, sometimes it can be difficult to distinguish certain symptoms. And some of them are very general and very hard to tease out what may be causing that.
So with that, I will bring up our, what's it called? Talking points.
Talking points.
Because I told AI what we're...
You're over the...
Oh, that's cool. I wonder...
What are you doing there?
What did that? Is it this?
How did you do that? It's something...
Okay, Lindsay's got a comment there. Yeah, let me move that thing out of the way.
It's that one. Yeah, that one.
There we go. We just need to move. There we go. I don't know that that's really helping us at all. Let me make that go away. So here's Lindsay's comment here.
Oh.
Where? No, not there.
Not there.
It's
somewhere.
Did you know that this cursor can go anywhere?
So find it again.
So it's like bringing my body to the people mechanic.
It's so true.
I don't know what's wrong, but something is off. And so I love...
And it never happens when you're there, right? When you take your car, it's not making that sound anymore.
So there's similarities.
So you got to describe it.
And there's things that aren't similar about going to the mechanic.
Somewhat, yeah.
Now, here's what's not similar. So, although with the more complicated electronics in the cars, it's getting more there. But with a car, there are distinct parts that man, and when I say man, I mean humankind, pretty much has complete knowledge of as far as how it works in that setting.
Yeah, probably.
With the human body, we're still discovering stuff at another level, a molecular level that is extremely complicated.
Yep.
No car is anywhere
quite
near
complex.
a significant fraction of how complicated the human body is and the mechanics that we have to, and not that we have an understanding at that level. No.
Right.
We have a lot of ignorance as doctors. I will own up to that, very much so. And we need to partner with patients because patients do know what's going on with their bodies. Having said that, we're going to get to some talking points.
Yeah. So maybe we should first start with the title of this show. Dunning.
I don't know my body.
I know my body can be dangerous. Yeah. And the Dunning-Kruger Effect. So where do we want to start with?
Oh, we should explain the Dunning-Kruger Effect.
Yeah, we should talk about that.
Because we haven't done that yet. Oh, you want me to? Okay.
Yeah.
I'm going to actually...
You're the one that came up with the title, so it's on you.
I'll probably just go to Wikipedia for it.
We're great sources
So,
here.
and I can put it on the screen, and I believe you can hear us when we're on the screen. So if I go to Wikipedia and say Dunning-Kruger Effect, and I will... Wait a minute. They have a graph that is not at all the Dunning-Kruger.
Yeah, that's
the classic, the classic curve.
The classic curve that we see when we look at the Dunning-Kruger effect.
Oh my goodness, it's not.
Come on, Wikipedia.
So I'll show it to you so you can see what I'm talking about. So and again, I know that our page is small and hard to read online. But we'll try our best here. The Dunning-Kruger effect is a cognitive bias that describes the systematic tendency of people with low ability in a specific area to give overly positive assessments of this ability or their ability. The term may also describe the tendency of high performers to underestimate their skills.
So there's a gap there from
let's look over here at the graph.
Time and knowledge, I guess you say, but it's not so much knowledge; it's more the being assured or the what's the word I'm looking for?
What's the word you're looking for?
Assurity? I don't know.
Competence.
Competence. Well, yeah, and actually we see this. We experience this ourselves. As young medical students, you see something and you've learned about it and it's there and you go to the clinic and that's your diagnosis. And the doctor says, I've never seen that before and this is definitely not that.
That's one example. Yeah. So early on, when somebody gets introduced to something, they watch a documentary on it, they read an article in a people don't get periodicals. They have AI talk to them about it and give them a description of it.
Yeah, it's good. Modern.
And then you feel like you have some knowledge about it. And so you enter a conversation with that or a situation and you say, I know about that. AI told me about it today, or I listened to a podcast about that. Blah, blah, blah.
I know. This is absolutely that. This is that. Yeah.
And then you find out, oh, wait a minute. Somebody who actually works in that field knows a lot more, and it's much more complicated than what they were able to get into in the 40-minute podcast.
Right. Yeah.
Or the trail I went down in reading medical journals on what I think I have.
Mm-hmm.
Told a lot about it, but not about where I made the wrong turn way early on.
Yep.
It was
right.
It was a virus.
That's a great example right there for sure. Yeah.
So it can happen, and it can happen to very educated people who think, don't allow themselves to be open to, there may be things I don't know. And that's something I want patients to know is I still discover 20 years
learning
here in this office, 30 years of practicing medicine. I still find new things, diagnoses I had not heard about before. And yet I'm able to practice medicine and help people and
and
aim them in the right direction when I don't know.
And as along that, medicine is constantly changing. I think the phrase that they told me in medical school, probably similar to you, is about 50% of what you learn in medical school will be obsolete or wrong by the time you're practicing medicine 10 years down the road or whatever.
There's dramatic.
Yeah, I know these are made up percentages, obviously,
to make an impression on. But the point is to get you to think.
Yeah, that you need to constantly be
now.
staying up on everything. There's constantly new information coming in, new medications that we need to learn about, new studies that may tell us more information. So that's all important. And typically the graph that we saw, as you become more competent, you get those 10,000 hours to become that expert in your field.
Right.
You don't feel as confident as you did initially with that small amount of knowledge. Your confidence goes down as your knowledge goes up.
Did we have that?
I'm still pretty confident in a lot of what I do, but it's not like we're...
Did we have that curve in the thumbnail for the show?
I think we did. Yeah, it is in the background there.
Maybe if I just go Dunning-Kruger Effect curve.
Yeah, that's the one we're looking for that comes up 10 times when you first search Google.
So, yeah. When you do, browser, that's it. So you'll notice that all of these curves have a similarity, and that's early on there's a peak, and that's the confidence that the learner has. But they're not necessarily that competent at that point. And then at some point, if they keep working in a field, they're going to hit that wall. And that's that drop in that curve that you see where they realize, oh, wow, I don't know. This is much more complicated. And then it takes them a while of learning to get back up to the confidence level that they had, if they ever do achieve that level of confidence.
Yeah, the whole idea of you don't know what you don't know. Until you get exposed to that.
And you were talking about medical students. I would go so far as to say that peak for me was probably in pre-med rather than medical school. That's probably where I hit a wall and realized, oh, wow, there's a lot more to this.
Oh,
That's why I'm going to 4 more years of medical school before residency.
Yeah, absolutely. Absolutely, because, there's such a huge gap there.
We do have a comment. Did you see that?
I didn't, but I'll take it and we'll back.
Okay. So we do have a comment, and it is from Dell and Murphy, I think is what we're doing. 3225. She's commented before. I really miss my favorite YouTube doc. My PCM won't listen. I've had metal mouth for over a mouth and you won't address it. Can y'all help? Actually, we can't practice medicine over YouTube. That
we cannot.
That is truly a thing the medical board has. Is you can't practice medicine over YouTube. But we can talk about the symptom of metal mouth. So there's people who talk about metallic taste.
Metallic taste. The biggest thing that comes to mind is side effects.
Side effects of medicine, especially lithium, because it is metal.
Metronidazole is
that one does too. I think there's some others.
There's a lot of them that.
Anti-seizure medicines, possibly. Mm-hmm. What else? Episodic pre-seizure. It could be like a smell. What's the word for the thing that comes on? Aura. Yeah, that's one thing that people sometimes will have.
Yeah. With the Dunning-Kruger effect, now that we've kind of teased that out, we probably should talk about
our talking points we said we're going to cover in
the other part. Well, you put up all these great things. You have all these talking points. We probably should at least hit them.
In this episode, we discuss the anecdotal trap, why humans are wired.
And that's what that little bit what we wanted to talk about. So anecdote is essentially, I read this somewhere. I experienced this once. It happened one time. It's a story I heard. So that must be going on. For example, somebody comes in and they say, oh, my friend had these exact same symptoms, and turns out they had lung cancer, or something.
Exact same symptoms. So of course,
that's got to be what you got, right? Whereas as physicians, we need to tease that out, because we start out with what's called a broad differential diagnosis, the options of what could be going on with those symptoms that are presented to us.
Make it very broad so you don't miss something.
Exactly. So that's, we fish with a large net and then slowly tease those out with the questions we're asking you. Does it have this? Are you doing this? How long has it been going on? Do you have these symptoms? And even then, in our best days, we're dealing with probabilities, right? So we can say, okay, you don't have, you're not coughing up blood, you don't have night sweats. We can be pretty confident that you don't have a cancerous process going on. You don't have weight loss. We're kind of asking you all these questions, and we're weaning down that confidence, not that confidence, the probability of what it might be, and trying to shift us towards something else. It's more, you've got a cough and you got green mucus and you've got a high fever, and maybe we're shifting more towards a infectious etiology as the cause, and our probability starting to go up on that end.
Post-obstructive pneumonia from the cancer.
Yeah.
See, it can get complicated,
and it's very complicated, and that's when we need to start to decide. Okay, do we need to bring in tests to help us out? Do we need a chest X-ray, CT scan, do some blood work, see if there's a white count, all these different things that will help us with that differential and increase the probability and possibility of what we're going down. So. We're all, even us doctors, have this anecdotal trap as well.
Also called availability bias.
Yeah, like for example, when I go to or read some of my CME, continuing medical education, that is right at the top of my mind as I go to see my next patient. So it's always like there on my differential, and I have that bias of bringing that in where it may not be appropriate or where it may not be as likely. Yeah, maybe you've experienced that as well. But that's one thing. It's good to bring those things in to know more, to expand that knowledge.
Sometimes it's because I've been misdiagnosing what
previously. Yes, sure, you didn't know.
And it actually is the new thing.
Yeah. Go ahead.
The fund of knowledge, comparing the 10,000 plus hours that you referred to of clinical training to the limited sample size of patient's personal history. We kind of covered that. Cognitive bias versus intuition. How to tell the difference between listening to your body and falling victim to a mental shortcut.
Right.
That goes. Yeah, that one. There's a lot of nuance to.
Yeah, intuition is an interesting word because intuition. To have intuition, you have to have some experience with something, and I can tell you.
Yeah.
Our intuition as doctors who practice this every day and see people all the time. Is probably a little more geared to picking up some of the nuances that point us towards a correct diagnosis versus somebody who, some random person on the street who sees you and hears your symptoms and says, you've got this because I read this in a book the other day or read an article on this. Intuition. Yeah, it's an interesting way to approach medicine. And intuition is not scientifically valid, but it can definitely, when I have had my intuition point me in the right direction before.
Yes.
And I think it's just because I have experience.
And there are studies where they will, I can't think of it off the top of my head, but I remember some specific things where there are certain tests that can be used to make a particular diagnosis. And what ended up being more accurate was the doctor's gestalt.
And strangely, we use a lot of these different calculators to calculate the probability of things, and one of them, the Wells criteria, right, for a pulmonary embolism. One of the things,
a blood clot to the lung.
Yeah, a blood clot. One of the questions is I forget how it's worded, but it's essentially like, is your intuition telling you that this is a pulmonary embolus? And if it's yes, it actually increases the likelihood that it is.
Which I find so funny that is also being applied by medical students who have never seen a pulmonary embolus.
That's true. They're using the same medical calculator. So that's why they have attendings.
Wells fellow.
Yeah.
All right, back to the comments and questions because we
appreciate your input.
Now it is possible that this show is being simulcast on Facebook, which when we tried that last time, we got a mismatch of our sound with our picture, and I don't know if that's still the case. If it is, it's fixable, but nobody's commented that, you don't match.
It looks like we are live, yeah.
Yeah, cool. All right, this is Lindsay Antoine. I want Dr. House to get obsessed with you.
That's so funny that you bring up Dr. House. Me. That's funny.
Okay. We'll get Huey Laurie right on over. Okay. And then also, again, Dell and Murphy. Thanks, guys. I already have pancreatitis, gastroparesis, scoliosis, fibromyalgia, sciatica,
Wow,
fatty liver.
that is a lot.
I don't drink, just hate the taste.
Yeah.
With all my medical problems.
With all my medical, there's with all those things going on, there's
that's a lot.
A lot going on.
Yeah.
Yeah, it can be causing symptoms, yeah.
Yeah, the interesting thing of when you have that kind of constellation of things going on, each new thing that comes along, you have to look at it a little bit differently in light of
those other things affecting it.
Yeah, the patient that you have in front of you that you wouldn't, and a patient didn't have all that going on.
Yeah, that's another thing that we probably should bring into this, that when you're talking to someone and they say, oh, you've got this, or
who doesn't know your medical history.
Yeah, that's
that's
exactly what I'm saying.
Yeah.
Or you read something, it's not taking all that into account. The medications you're taking that could be causing some of the symptoms that you're having, the other medical diagnoses that may affect it more or less towards that diagnosis. So yeah, those are things that we're trained to do, and that is a complicated process that takes experience to be able to bring all of that in. Yeah.
So yeah, we actually are on Facebook, but no comments coming in from it.
Yeah.
Okay, so let me just check one more time because we did hit all the talking points, and I thought you did a really good job, Dr. Wayne. I was impressed.
Let me know.
There we are. We are good. Okay. Anything else? Go ahead.
I don't think so.
Nothing special from your patients you saw this morning since we last spoke? Okay.
No,
this afternoon.
No.
So I wanted to mention that I enjoy doing the live streaming, and so I'm doing it with my personal YouTube channel and actually TikTok too, doing some music stuff under the name Dr. Vaughn. There's probably a link for it somewhere in the description, and it's following the journey of a middle-aged guy who's taking up music. So if that's of interest to you, subscribe and mark the bell for the
sounds way more interesting than some young guy taking up music.
You should do it.
Your life experiences, bringing that into it, man.
Yeah, such richness. Okay, thank you, Dr. Goyne. Nice plug there. And thank you, all of our viewers, especially those on Patreon, which is available for those who want to be a part of this, and Lindsay Entwine, who gets special mention.
Yeah. So why do we do this? Next time you go to see your doctor, it's okay. You want to have that discussion. You want to bring up what you're having. You can even bring up, what you think may be going on, but be open to that doctor's expertise. And
there's two people in the conversation.
Yeah.
So make sure you're one of them, and that the doctor also is a part of the conversation.
And we're here to lend you our expertise to help you out.
And be open to the possibility that they know of possible explanations that you've not heard of before. It's possible.
Yeah.
And they should be open to the possibility of that also. It needs to go both ways. Okay. Thank you, Dr. Wayne.
Yep.
Until next time.
Hey, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn telling you to stay in good health.